All right, welcome everyone to another high-energy explainer here on Confused Neuron. So go ahead and grab your mental whiteboard markers because today we are going to completely master the pharmacology of the gut and the groin. We're going to draw out these concepts step by step so you can lock this knowledge into your brain for good. Okay, let's kick things off with a pretty high-stakes question. What is the absolute most dangerous thing about vomiting? Now, I want you to think beyond just having an upset stomach, way beyond the discomfort, and definitely beyond the gross factor. Just give it a second. What's the real danger here? Well, if you guessed dehydration, hey, you're close, but the actual correct answer is electrolyte imbalance. And if it gets severe enough, the second most dangerous thing is volume depletion. Think about it. When you lose all your fluids and your electrolytes go completely haywire, it can literally lead to cardiac arrhythmias and brain seizures, effectively turning you into a vegetable. That is the massive physiological battle we're up against, and it perfectly sets up exactly why we need to understand this to save our future patients.
Section 1. The anatomy of emesis. Why we puke.
So think about normal digestion for a second. Food moves from proximal to distal, right? From the oral cavity straight down towards the tail end. But vomiting? It's the exact opposite. It's moving in what we call the ORAD direction, distal to proximal. And honestly, here's a really fun fact about this. It's actually a brilliant protective mechanism. If you have severe acidosis, vomiting gets rid of stomach acid to help balance your blood pH. Or if you're hypoxic, vomiting empties the bowels so your body doesn't waste its precious oxygen on digestion. Your body is quite literally sacrificing the gut to save the brain. Now, since vomiting is a reflex, we absolutely have to memorize the pathway. And I've got a fantastic mnemonic to make this super easy. SRACER. You can think of these reflexes kind of like cockroaches in your nervous system. They're automatic and really hard to kill. Let's break it down. S is the stimulus, like, say, sticking a wooden spoon down your throat. R is the receptor that actually detects that irritation. A is the afferent nerve, specifically the vagus nerve, sending that distress signal up to the brain. C is the center in the brain. E is the efferent nerves commanding your diaphragm and abdominal muscles to contract. And finally, R is the response. You vomit. So the most crucial point here is that C in our SRACR mnemonic. The ultimate command center for all of this chaos is located in the medulla oblongata of the brainstem. Specifically, it's called the chemoreceptor trigger zone, or the CTZ. You basically have to get in the zone to vomit. And, speaking of reflexes, do you happen to know why Ivan Pavlov, the pioneer of the classical conditioning reflex, had such great hair? Well, because of conditioning, of course. Okay, bad jokes aside, let's actually look at how we can block this center.
Section 2. Antiemetics. Stopping the puke.
All right, here are the pro tips that your average professor probably won't teach you in a standard lecture. We are hacking the drug suffixes. If a drug ends in cetron, like ondansetron, you can bet your rent money that it blocks the serotonin 5-HT3 receptors on the vagus nerve. If it ends in pipent, like a prepitant, it's an anti-neurokinin 1 receptor blocker, directly targeting the CTZ. And then we've got metoclopramide, which blocks the D2 dopaminergic receptors, also sitting right there in the medulla. Do you see the pattern here? We are literally just cutting the communication wires to stop the reflex. But wait, what if the vomiting isn't even coming from the gut? What if it's motion sickness? Well, we can target the inner ear using diphenhydramine to block H1 histamine receptors or scopolamine to block M1 muscarinic receptors. And what about anticipatory nausea? Like when a first-year medical student sees a cadaver for the very first time and just wants to hurl. For that, we can use benzodiazepines, acting on GABA receptors up in the cerebral cortex to calm things right down. It is all about matching the specific receptor to the trigger. Moving right along to Section 3, UTI antimicrobials, the basics of selective toxicity. So, selective toxicity. It's basically the ability to injure or kill an invading microorganism completely without harming the host cells. The key here is biochemical differences. We are exploiting the fact that bacteria have cell walls and totally different metabolic pathways than human cells do. We essentially send in a drug that acts as a highly targeted assassin, perfectly designed to recognize only the bacteria. Let's break down the treatment algorithm for UTIs by matching the drug directly to its bacterial target. For acute cystitis, we use fosfomycin. It specifically blocks cell wall synthesis. And here's the best part. Because it concentrates so heavily in the urine, you only need a single one-time dose. Then we have the fluoroquinolones, like ciprofloxacin, which target bacterial DNA. And finally, cotrimoxazole, which is actually a combination of trimethoprim and sulfamethoxazole, and that acts as a super potent inhibitor of bacterial folic acid synthesis. But of course, no drug is perfect, right? We have to talk about side effects. When we use cotrimoxazole, we definitely have to watch out for hypersensitivity, things like skin rashes, nausea, and some hematologic toxicities. But I want you to draw a giant mental red circle around this next one: hyperkalemia. Elevated potassium. This is a very special side effect that you absolutely must remember for your exams, and more importantly, for your future patients when you're prescribing this folic acid antagonist.
Section 4, UTI antiseptics and analgesics. Now, typically, systemic antibiotics go everywhere in the body, and bacteria can eventually mutate to resist them. But we also have urinary tract antiseptics, specifically a really fascinating drug called methenamine. Methenamine is primarily used for chronic suppressive therapy, just to reduce the overall frequency of UTIs. And the absolute biggest benefit of methenamine? Bacteria simply cannot build resistance against it. No way. Why? Well, let's look at exactly how it works.
Okay, this mechanism of action is literally mind-blowing. Methenamine hydrolyzes into ammonia and formaldehyde in acidic urine, specifically when the pH is 5.5 or lower. It literally turns into embalming fluid right there in the bladder, totally denaturing the bacterial proteins and nucleic acids. It's basically chemical warfare that bacteria just can't adapt to. But there is a huge contraindication warning here. Never ever mix methenamine with sulfonamides, like cotrimoxazole. Why? Because they react with the formaldehyde and drastically increase the risk of crystalluria.
Wrapping up our drug list, we have nitrofurantoin. It's a fantastic first-line therapy for uncomplicated cystitis that inhibits bacterial DNA and RNA. But crucially, you have to avoid it. It is heavily contraindicated in patients with impaired renal function due to a really high risk of adverse events. Finally, let's talk about pure symptom relief. Phenazopyridine is a urinary analgesic. It actually has zero antimicrobial activity. It just soothes that burning dysuria. But you absolutely must warn your patients about its special side effect. It's a dye, and it will turn their urine a bright, glowing orange. Trust me, if you don't warn them, they will panic.
And that brings us to the end of our whiteboard session for today. So, how will you use the mastery of selective toxicity and precise receptor targeting to save your future patients? We've hacked the suffixes, we've traced the pathways straight from the medulla down to the bladder, and armed you with the exact mechanisms you need to outsmart both the gut and the groin. Take these high-yield concepts, apply them in the clinic, and never be a confused neuron again. Keep learning, keep studying, and I'll see you in the next explainer.